So what we want to do is talk a bit about, and I was very intrigued last night to think about some of the problems that you were describing in the several presentations in terms of the kinds of medications that kids are actually on and their distribution. And now this is all inpatient use in New York State. So we have a similar kind of distribution, about 600 beds. Sometimes it's in the 500. And so our atypicals are usually our biggest category, but mood stabilizers as well. And as you kind of know, guess what? It's not for psychosis. It's for everything but psychosis. So psychosis is in the mix, but it's your disruptive and depression and some now bipolar. People are pretty conservative in New York about throwing that bipolar label out. I think the Columbia influence, which is more conservative. And we don't have the same water that they have at Mass General. So I think it must be the water or something. It's a manic agent in the water at Mass General. So, but this actually distribution isn't a whole lot different than what we see kind of in the national data sets from inpatient kids across the country. So this is from IMS Health that does for pharmacies and drug companies kind of what are doctors doing. And so can you look kind of where our distributions for now, this is atypicals, and I'm focusing on those because that's kind of the smoking gun. Mood stabilizers are going to be important, but these are the ones that has everybody kind of up in arms about metabolic syndrome, TD. Many of our mood stabilizers have indications for seizure disorder. Of course, the field is changing recently with indications for the mood stabilizer, for the atypicals for schizophrenia and bipolar. And a couple of them autism as well. So it's a moving target, but clearly the atypical issue is a very, very important one, and we've seen these dramatic rises. Now this is what is so fascinating. So why are we all, to my mind, why are we here today? It's because of this. We're all over the map. So yeah, these are all the inpatient units in New York. And look at the different, the drug of the week is all over the map. Some places it's olanzapine, others it's quetiapine. Some places they never touch clozaril. Some places it's up to 25%. Isn't that interesting? Anybody have thoughts about that? Why would that be? Issue of habit, what you're exposed to. Well, who was the last drug rep you saw? Did he give you a cup of coffee or a coffee cup or something? I mean, it's all of those are not trivial issues. Probably much larger than we think. Other thoughts? Why this would be?
The type of population that you treat.
How's that?
Type of population, type of children that you treat.
Does the population differ from unit to unit to unit? As best as we can tell in New York, they don't.
Any differences in the formulary between facilities?
No, they all got the same formulary. New York State formulary.
The training programs they went to.
You know, it's interesting because the first one to come out in the market, of course, was risperidone way back, right? And you would kind of think, well, I guess everybody would have started with risperidone and gotten kind of comfortable, but there's not that pattern at all. So it's an interesting issue because in many ways, we wish we had more data. Other thoughts of why this pattern? Yeah.
You know, I work at a juvenile detention center, and I think that there is a lot more popularity for the quetiapine among the adolescents. And a lot of them are resistant to even consider any other medications, and there's, you know, the Q-tabs on the streets, and I wonder if that has certain influence on why quetiapine is a lot more prescribed.
Could be, and I didn't know that. Well, you know, and of course these do have different side effect profiles. So if I had an overweight kid, which is the one I would most not want to use, olanzapine. If I had a kid that I'm hoping to get away with little or no weight gain, what agent might I use?
Geodon.
Okay, so Geodon or Abilify potentially. But what we now know is there weight gain associated with both of those agents? Yes, there is. So they all do lead to to detectable and significant weight gain. So, but there clearly are side effect differences. And so you want to really pork a kid out, you put him on olanzapine, at least on, you know, if you're not knowing a kid, that would be the one you'd take the greatest risk with. Yeah.
So what about, you know, you trying Risperdal and it didn't work and you switch to Abilify and, you know, then you take the picture at that moment, you know, when there is more of them being tried on a particular one because there have been changes, you know, and so it depends when you measure.
Well, so do you mean kind of like a kid's brain has changed and he may respond to one at one point and stop responding and now respond to something else later on?
Or not necessarily. Maybe you are just starting to treat and, you know, you try the Risperdal first.
Yeah.
And they didn't respond to Risperdal the way you want.
Oh, I see what you mean.
And then you
Find another one.
do another one.
Yeah.
You know, and,
Well, and that's exactly what kind of the guidelines both that I've been involved with, and actually I've been involved with working with the Florida algorithms as well, working with Bob and others a couple of years ago. So the Academy of Child Psychiatry guidelines, the Florida guidelines, the TMA, the TRE guidelines, they all kind of make that point. If the first one doesn't work, you know, and we've treated the primary disorder and we've done the psychosocial interventions and all those other steps, we still got this kid who's pretty aggressive, and the first one doesn't work. Yeah, we're going to go on to the second one. Yeah, no, that's absolutely right. So that could be. I mean, is it possible all of these quetiapine kids got here because they first went through risperidone? And these are like your kids in one sense, that they are chronic, long-term. What's your average length of stay in the SIPPs?
6 months.
6 months, about the same as New York. So probably very similar. And so
Cost, that's dictating selection.
cost? Well, of course, risperidone is generic now.
Yeah, because we have a problem when we discharge kids from the SIPP, that we may put them on medication in the SIPP, that, you know, Medicaid will pay for it, or other insurance companies. But when we discharge them, you know, like Abilify is not generic, it's very expensive.
Oh, it's terrible. Yeah. Yeah, I mean, if I were kind of running a state pharmacy, I would say, unless there's a contraindication to use risperidone, that's what you start with. I mean, that would only be for reason of cost and has the most data, but other than that, there's no reason.
You get kids who lactate on risperidone.
Yeah.
You have to
So you do see that, yeah. But now you know, I mean, you found it, yeah. So any other thoughts on why we see this? It's pretty interesting.
I think I would like to say one thing. I've seen, I have a Baker Act unit, and I get a lot of kids on the Baker Act, which is our acute, you know, involuntary admission unit, you know, in Florida. Basically, Seroquel is, out of all the antipsychotic medication, is also being abused to hallucinate.
Interesting.
This
Is that right?
Kids like it, they hallucinate on.
How do they do it?
Seroquel. Benadryl,
And snort it?
crushing it, snorting it, Benadryl. They're using actually Benadryl and this one, and actually.
Benadryl and Circle.
That's why I stopped using these kids with abuse. You know, they have the background using drug. I don't use Seroquel.
Very
Or
interesting.
use
Is this well described in the literature?
Yeah,
Are there good case reports out there?
yeah, Xanax is Z bars and Seroquel is Q bars.
Very interesting.
I use now the XR where they can have the high.
So thank you. I've learned something new here today. Okay, that's good. That's good. We're teaching each other. This is very good. Okay, well, you know, it was these kinds of problems that got New York State interested. And they said, so when I came to New York, probably 2000, so a decade ago, just about a decade, so we jumped into this kind of with both feet. And that led 3 or 4 years later to the publication of this kind of guideline. And what was interesting thing about the guideline was actually for inpatient units. It wasn't for general outpatient. But the field's come a long ways, although we don't have a lot more studies of impulsive aggression of these agents under double-blind, placebo-controlled conditions, because there's not a lot of money to be made in it, basically. for many of these companies, and there was real concerns about FDA giving an indication, and they never did for any of those agents, but they have done it for obviously for autism, with irritability associated with that. But it was the variability that New York State was worried about, and so what happened as part of that process was developing a guideline. I'm not going to talk too much about the guideline, but I am going to talk about specific behaviors that are both encompassed within the Florida algorithms, the Academy of Child Psychiatry, and other approaches, and together hopefully we can do a little problem solving around them. So this is the direction I want to go. This is kind of like let's make a deal, but instead it's let's get real. You know, let's really pull off the gloves, talk about when you use these agents, and talk about quality. So what I'm hoping we can do is really kind of be real candid with each other, those of us who are prescribers, or those of us who monitor. Can we really have an honest, complete dialogue about what we think the issues that pertain to quality are? What are the biggest challenges? And it might be something I do. Nurse slips it under my nose, and I don't know the whole situation. I just fill it because I can't get home if I don't write this script. Or I'm going to get called later. It might be. Or it could be seclusion restraints that kind of morph into a lot of PRNs. Could be cocktails. Could be things you see. Could be things that others see. Doesn't matter. So let's just talk about what's your perception of the biggest quality issues in the SIPPs pertaining to medicines and in the state pertaining to psychotropic medicines. Hands. Biggest issue.
Polypharmacy.
Polypharmacy. Okay, it's got to be a huge one. Everybody's saying it. And so now the assumption is, because it cuts both ways. People say, wait a sec, we treat AIDS with multiple drugs and we treat cancer with 4 or 5 drugs. That's the answer. Isn't mental health the same way? The problem, of course, is in all those studies, they said, let's test 2 very carefully. Now we'll test what happens when we add 3. And they say, you know, that is more effective. So we have all these things where we have none of that data because I can be under pressure. And I'm very glad for a placebo effect for the next 2 weeks after I've given the drug and everybody's relieved. And then I've got some other problem later. So polypharmacy is a big one. And there might be some cases where it's a great thing, and some cases it's a disaster. What else?
I think the biggest problem is misdiagnosis.
So maybe it's not how we use the med. I'm using the med because I have a whole false set of assumptions about what I'm treating. And the med problem is related to an assessment diagnosis problem. Okay, very interesting.
But just to go to what John said, I mean, the diagnosis is a problem, but it's also that, like said, so many of these kids have not just one clean diagnosis. They've got symptoms in so many different areas. It's difficult to capture it with one diagnosis. So it's not just one diagnosis, it's comorbidity. And then all of the psychosocial issues, family issues, all that goes on top of it.
That
really
throws it
really
out, so yeah.
Figuring it out, what is the core of what I'm trying to treat here?
Yeah, boy, that's for sure. What am I treating? He's got 4 diagnoses.
Right, it's formulation skills, you know.
Yeah, yeah. And what's interesting about that, it's also Sherlock Holmes historical detective archaeologist historian skills. When was he started, and what dose, and then what happened, and then what? How long did he take it, or what dose, and oh, you say the dad killed the mom, and right at that same time, you know, oh, there's a little stress going on in the life, you know. So that's pretty daunting. Yeah, great point. Yeah.
No, and I think it's the same to follow that sometimes we choose to treat the symptoms because it's so many things that then the diagnosis is sometimes unclear. I say I prefer to treat the symptoms at this time. Is the main symptom is aggression, let's treat the aggression. And then we will refine, you know, like bipolarity is just the trace of the axis 2 with the conduct disorder, but at least to treat the symptom, which is the emergency situation. Sometimes we try to do that.
Okay, so that's a very pragmatic approach. So, yeah, we've got the problem with polypharmacy. We've got problems with maybe the whole assessment way we're doing things is totally wrong. Time pressures that maybe we end up saying, let's just get pragmatic because of the complexity of the task. Okay, yeah.